Welcome to Mental Health America's Regional Policy Council meeting. Mental health care can't be denied. People are coming in pretty quickly, so I'm going to give it 1 minute and then I'll start telling you more about today's program. While folks are coming in, we'd love to hear about who you are. So feel free to put your name and your organization in the chat. And we're going to welcome you throughout the day with lots of interaction. Let me tell you a little bit about who I am. I'm Debbie Plotnick. I'm Executive Vice President for State and Federal Advocacy at Mental Health America, and I have the great privilege of coordinating our Regional Policy Council. And for those of you who are not familiar with MHA, although I think most of you certainly are, we're the oldest national advocacy organization founded in 1909, and we're actually celebrating our 116th anniversary this month. We're so glad that you're here with us to help us celebrate, and as we give our annual Governor's Leadership Award. I want to tell you a little bit about the RPC very quickly. Our Regional Policy Council, RPC, we all love alphabet soup, is coordinated by 4 of our best affiliate policy folks. And you're going to hear from several of them today as part of our program. We're also going to have several opportunities throughout the program today for you to not only interact with us with questions that we'll do our best to answer in the chat, but also we'll have several QR codes. So please get your phones out and be ready, because there's actions you can take and information that you'll be able to have. I'm going to tell you very quickly about our agenda for today. We had to move some things around, and that's just fine, because you're going to be hearing from some amazing folks. You're going to hear, in addition to Governor Pritzker getting an award, and we'll tell you all about that in a minute, you're going to hear from the Commissioner and the Deputy Commissioner of Behavioral Health in the state of Tennessee. You're going to hear from Allie Gardner, who's a researcher at the Georgetown University McCourt School of Public Policy, their Center for Children and Families. And we're going to dive deeply into Medicaid. We're going to talk, the Commissioner and Deputy Commissioner will tell us about workforce and how we grow workforce in the states. We're going to hear from 2 of MHA's experts, one of our Regional Policy Council reps, Barb Johnston from MHA in New Jersey, and Tim Clement, our Vice President of Federal Affairs at Mental Health America National, and they are going to dive really deeply into parity. We're going to learn about what happens if folks have asked for insurance, asked for coverage, and it hasn't happened. We're going to hear from Joe Feldman of Cover My Mental Health. And we're going to then hear from Shelley Polanco, who is another one of our Regional Policy Council reps, our experts in policy, and she's going to tell us about expanding crisis care. And she is from Vibrant Behavioral Health, one of our affiliates and home of the 988 suicide and crisis hotline. So we're going to get started right away with our housekeeping things. Oh, you can see it up there. I'm not busy not looking at it. The meeting is being recorded, and the slides will be emailed to you after the meeting. I'm afraid we don't have any CEUs for this meeting, but please feel free to share when you have a link with the recording. You can feel free to share it widely. We're going to move into the highlight of the governor's meeting, which is the governor's presentation. We need the next slide there, please, Alicia. And it is my great pleasure to introduce someone who's very important at Mental Health America. Oh, I forgot them. Back up, Alicia. See, you weren't moving the slides. I forgot one of the most important parts of housekeeping. The Regional Policy Council could not be doing our programs that we do, sharing our information, and being here today with you without our industry partners. So I want to make sure that I thank our industry partners: Bristol Myers Squibb, Compass, Johnson & Johnson, Pfizer, Myriad, Neurocrine, Otsuka, Sage, Biogen, the Takeda Lundbeck Alliance, and Teva. We truly appreciate your partnership with us. You make it all possible. Now it's time, let's move those slides along, please, to introduce Mark Hireman, who is a very important part of Mental Health America, both at our national level and MHA of Illinois. Can we highlight Mark? And Mark is going to tell us about why it is that we chose to honor Illinois Governor J.B. Pritzker this year. Mark?
Good afternoon. Thanks. I'm here on behalf of North America of Illinois. Also here is our Executive Director, Ray Connor. Founded 115 years ago by the famous social worker Jane Addams, the Mental Health America of Illinois is the oldest statewide mental health organization in Illinois, and of course a proud affiliate of the national organization. Why are we honoring Governor Pritzker today? Well, I don't have time to list all of the things that the governor has done to improve mental health services in Illinois, so I will just focus on a few. In 2024, the governor sponsored and worked to enact the Healthcare Protection Act. This law amended our health insurance code to make dramatic improvements to commercial health insurance in Illinois. Here are some of the highlights relating to mental health. It requires health insurance providers to have a higher ratio of behavioral health providers in relationship to the number of persons insured. Sets a floor to make sure that there are always enough providers available. It strengthens requirements, making sure that patients do not have to travel too far or too long to get to a mental health provider. It provides fines for insurance companies that do not have adequate networks of mental health providers. And if an insurance company does not have an adequate network of mental health providers, it allows patients to go outside of network without paying more money in co-pays or any other expenses. It requires continuity of care when you change from one network to another. It requires insurance companies to have an updated net directory of providers with fines imposed if they do not. It requires insurance companies to use independent third-party criteria in determining what services are medically necessary. It also prohibits step therapy. The Healthcare Protection Act also did something that applies not just to commercial health insurance, but also to our state Medicaid program. And I think most of you know that Medicaid is the largest funder of mental health services in every state. Certainly it is in Illinois. So for both health insurance and Medicaid, it prohibits prior authorization for inpatient psychiatric care. Prior authorization often results in delays or denials of necessary care. And when someone needs to be hospitalized, they often need that urgently, and the delay can be devastating. I would note that despite all the good things that the Healthcare Protection Act has done just last year, the governor is not resting. In yesterday's State of the State address, he proposed eliminating prior authorization for all behavioral health care. This is very important because most behavioral health care, as you all know, is provided in the community, not in hospitals. Getting prompt and effective community care is overwhelmingly helpful in preventing expensive and sometimes traumatizing hospitalizations and other bad outcomes, including family and employment disruptions, homelessness, and sometimes even involvement in the criminal justice system. Mental Health America in Illinois will be working enthusiastically to help the governor get this new legislation enacted in 2025. We know that the cause of behavioral health has many friends in the Illinois House and Senate who were thrilled to hear the governor's announcement yesterday. Finally, I will just mention two other things the governor has done for mental health in Illinois. He has appointed a state chief behavioral health officer for adults to coordinate the state efforts of all state agencies. It is often difficult to figure out how to get mental health services, and state agencies don't always coordinate to figure out who's supposed to be doing what and have appropriate handoffs between different systems. So having a chief behavioral health officer is really important. As important, if not more important, he just recently created a new system called Beacon, which is really a beacon of hope for young people. He created a young person's coordinator, and that woman, Dana Weiner, has created this beacon system in which young people and their families can go to a portal, a state website that will give them access to all children's mental health services in the state, no matter what department they're provided by. So please join me in thanking Governor Pritzker for all he has done to improve mental health services in the state. We are very proud to have him be honored today and thankful that he has continued to work to improve the mental health of all of the people in Illinois.
Hello, everyone. I'm Governor J.B. Pritzker, and I'm so honored to accept the Governor's Leadership Award from Mental Health America. As many of you know, expanding affordable, accessible mental health is an issue near and dear to my heart. During my time as governor, I've worked tirelessly to increase the state's investments in mental health services, focusing on equity all along the way. I'm very proud that Illinois is leading by example, using our laws to hold insurance companies accountable for failing to cover mental and behavioral health services. We're improving access to meaningful mental health care and resources for people all across our state. And our partners like Mental Health America are making those efforts easier. We deeply appreciate the important work you do. Again, thank you so much for this honor and enjoy the rest of today's ceremony.
Mark, thank you so much for introducing your governor and telling us more about him. He is truly inspirational, and your state, the state of Illinois, has been an example and provided much model mental health legislation and a great model for the types of things that are being put on, being instituted in Illinois as other states want to copy that. We heard a lot about that at one of our other regional policy council meetings. We truly appreciate him and his work. He has hit on the things that matter to Mental Health America greatly: early intervention, prevention, access, parity, getting rid of onerous things that keep people from getting what we need. And we are just thrilled to be honoring Governor Pritzker. So thank you, Mark, for your introduction of the governor and telling everyone why we think so highly. And the Governor's Award is something that we're always honored to do every year. And we have had many governors over the past 10 years from both sides of the aisle. Mental health, as we know, is not a partisan issue. Mental health affects everyone, and governors of from many states, from all parties, have really been wonderful. And Governor Pritzker is someone we've admired for a long time. So thank you so much. I need to check with our team. Is everybody ready to go from the state of Tennessee? As I see Commissioner Williams, and we're thrilled to have her. You know, we're going to talk about a lot of things today. We know that access is so important, as we just heard, parity, we're going to hear about all those things. But without something that really matters to all of us, and we know that we have had a great deal of trouble over many years with a workforce that just can't keep up with everything. We know that peers are important. We're seeing more and more peers, but if we do not have clinicians in place to serve people, then we're not able to get people what they need, no matter how many barriers we move out of the way. Given that we're looking at how do we improve workforce, we are so thrilled to have Tennessee Mental Health Commissioner Marie Williams with us today. She has done an amazing job in the state of Tennessee of growing their behavioral health workforce and in growing services to the people of Tennessee. And we invited Commissioner Williams and Deputy Commissioner Yancey. Is he here with us?
Debbie, I'm texting him right now. We literally just got off a call. Hey, because I don't think he's on yet.
Okay. If you're ready to go, Commissioner, we can get started with you, or we can move to Ally Gardner. I mean, and that's completely up to you.
Yeah, we're on a very tight time frame today. So Debbie, I just want to thank you for your leadership. You do a fantastic job with MHA, and I've always admired and thought very highly of the work that you do. So I'll go ahead and begin and just texted him, and hopefully he's going to get on here in a minute. This issue of workforce concerns, workforce shortages, has been something that for many years we've been looking at in Tennessee. And as we looked at it, we brought together a group of individuals, cross-section of universities, providers, consumers, funders, TennCare, you name it. We brought together an unbelievable group of people. And Matt Yancey, who I think is on here now. Matt, are you on here? Okay. Matt Yancey, what I wanted to tell you, he really is the person, as our Deputy Commissioner of Community Behavioral Health Programs. He's really the person who took this and ran with it in concert with our Medicaid agency. And we co-led these meetings and came up with pretty impactful ways that we could intervene. So Matt will go over that PowerPoint, but what I wanted to share with you guys, something that we had said to our governor and to our legislature, you know, if you have to see a different doctor every 6 months, like you've got a general practitioner, and that changes every 6 months, that's pretty much what our consumers and families were dealing with because of the turnover and because of the vacancies, because we weren't addressing some key areas that we could to make a difference. So when you look at this PowerPoint that Matt will go over, two things I'd like you to look at that have had the biggest impact, and it's so easy. Any state could do this and have the same impact. One of those is providing behavioral health scholarships for individuals that are pursuing a master's in counseling, psychology, social work, anything in the social services, whereby they could give back to our communities by working for our nonprofit community mental health centers. When we opened that portal, we had 800 applications within a 3-month period. We had to close the portal. Our funding, as Matt will go over, he's on here now, our funding has gone a pretty far away, but we are asking for more funding in this budget this year because each of those individuals has to agree to work in one of our mental health, family, consumer, substance use provider networks for the same amount of time that they got that scholarship for. I can't tell you how impactful that is going to be in this state. That's one of the main things that I've been grateful to see get funded and been grateful to see the outcomes with that. But Deputy Commissioner Yancey is on here. I will turn it over to him as he is the star of this presentation. Matt, you're up.
Hey, thank you, Commissioner. Can you hear me okay?
Absolutely.
Awesome. Well, first, I just want to say thanks to Mental Health America for giving us a few minutes to highlight strategies that we've used in Tennessee to bolster the public behavioral health workforce. We'll hit the high points today. And Debbie, Alicia, I'm not sure if you've got the controls on the PowerPoint, but we can go to the next slide. All right, so I wanted to start and first talk about our relationship with TennCare. For those who may not know, TennCare is Tennessee's state Medicaid agency. And probably like most states, the public behavioral health system, and when I say public behavioral health system, I'm talking about people that serve people who are uninsured, who are indigent, or who are covered by Medicaid. Our partnership with TennCare has been really critical in addressing these workforce challenges that most states, if not all states, have been impacted by. And I'm next going to talk about the work group that we created back in 2021. So if we can go to the next slide. We'll back up one more there. There we go. So as I mentioned, about 4 years ago, our department, in partnership with TennCare, our state Medicaid agency, said, you know what, we need to come together and collaborate and think through what ways we can cultivate a new workforce here in our state related to behavioral health, and what are the things that we need to do to shore up and bolster the current workforce here in Tennessee. The system, as I'm sure most of you can attest, is only as strong as the professionals who staff it. So Commissioner Williams and Director Smith, the TennCare director, said, you know what, let's put together a behavioral health work group of which we would facilitate, we would convene, but really empower the work group members to come up with solutions. So what we did back in the summer of 2021 is we convened a stakeholder group that included provider organizations, providers that both our department and TennCare contracts with. We included advocacy groups. We also included colleges and universities, recognizing that we needed to bring them to the table in thinking through pipeline planning and how do we attract more people into this field. We also included our planning and policy council chairs. So probably most of you are aware that each state has a planning and policy council connected to its block grants, its SAMHSA block grant. So we included the planning and policy council chairs on this work group as well. Some important notes about the work group, and I've learned this from experience over the years. We didn't want to meet for, a year or 2 years because time was of the essence. We also wanted to create a report that was digestible and understandable for all people. So in keeping with the way I kind of operate, we said, look, we're going to meet 3 times, and each time we meet, we're going to have one goal. So you can see the goals here on the slide. The first time we met as a work group, we identified gaps and needs, not just looking at national data, but most importantly, data specific to the state of Tennessee. The second time we met, we discussed strategies. That was probably our longest meeting, where people started to think through what are the ways that we can address the gaps and needs that we discussed in the first meeting. And then the third time we met, we rolled up our sleeves and created a report. And as you can see, this report was really written for key decision makers, those being leaders in our state, people in our legislature, our governor's office. And in this report, it included both, short-term and long-term strategies for consideration for those key decision makers here in Tennessee. If anyone's interested about this report, there's a link there at the bottom. I'd highly encourage you to look at it. And if you have any questions as you review it, please reach out to me. My email information will be at the end of this presentation. We'll go to the next slide. Here you can see the highlighted strategies that are included in our report, strategies that were identified by the work group. The first thing, as you see, is payer reimbursement rates. That probably doesn't come as a surprise. The primary strategy the work group identified was, hey, if we want to address workforce challenges, the payers need to reimburse at a higher level. So that was probably the primary strategy. You can see others here related to licensure, professional licensure modifications, benefits, incentives, pipeline planning, internships, as well as student loan forgiveness programs. These were the 8 things that the work group identified over the course of those 3 meetings. Next slide. So this is where we're going to pivot into, okay, so we put together this work group. You met 3 times, you had 3 goals, you had a report. Well, what happened? I'm sure a lot of you have been involved with task forces and study committees and work groups that generate reports, and the reports may be great, but the action that comes out of them may often fall short. That was not the case with this report. So we'll go through what's happened since we did this back in 2021. Next slide. Payer reimbursement rates. You remember me saying that was the priority number 1. So here over the past 3 fiscal years, you can see the investments that have been made in the public behavioral health system by our governor, Governor Bill Lee, and of course, our partners in the Tennessee General Assembly. And these are relevant both to our department and TennCare. So in fiscal year 23, you can see that $18 million was added to our budget specifically for provider rate increases. It wasn't necessarily to serve more people. It wasn't to provide new services. It was actually to stabilize the workforce by increasing the amount of funds that we pay for the services that we were providing, or funding rather. So we were able to raise our fee for service contracts. We were able to raise our cost reimbursement contracts. And we were very clear that these dollars were to go into the salaries of frontline staff. So that was a big deal. You can also see in FY23, our partners at TennCare also received a significant increase of about $12 million to support the community mental health centers here in the state, our mobile crisis services, comprehensive child and family treatment. So between those 2 departments, our department and TennCare, just in that 1 fiscal year, there's $30 million invested in the system. FY24, the theme continued. Thanks to the governor and the legislature, another $18 million came our way, again, just to further raise our rates. That was of super significance for our state to have $36 million in the course of 2 years set aside just for rate increases. Our partners at TennCare, as you can see here, also continued down that same line with over $15 million added to the system for community mental health centers, for housing services, for mobile crisis. And then this current fiscal year, we received an additional provider rate increase of $6.3 million. And then TennCare, through its shared savings, $28 million has been added to the public behavioral health system this fiscal year. So I don't know what all these numbers add up in total, but over the course of 3 years is super significant. And I think TennCare and our department both would point back to the work group as being a primary driver of these increases. Next slide. Some other things related to the strategies that the work group identified. We had a special session convened by the governor back in August of 2023, focusing on public safety. This was right after, or it was the same year rather, of the Covenant School shooting here in Nashville. And everyone was really interested in what can we do to address public safety, school safety, and of course, behavioral health was part of that conversation. You can see from that special session, $12.1 million was provided to our department in non-recurring funds for sign-on and retention bonuses. That was another thing the work group had identified. Those funds have gone to 38 different treatment organizations here in our state. And with all these bonuses, there's a requirement that people commit time to the agency they're working with, whether they receive a retention bonus or a recruitment bonus. You can see here on the slide the positions that were relevant, or should I say are relevant to this bonus program. And we thought broadly. We didn't just think about the clinical staff, but you can see we included case managers, technicians, all the people that are part of the public behavioral health system. We wanted to benefit from this bonus program. And I think I lost the slide, and now it's back. Thank you, Alicia. You can see since we started this back in December of last year, over 4,000 people in the public system in here, Tennessee, have benefited from these sign-on and retention bonuses. Next slide. Additional funding that came to us from our special session, $50 million in non-recurring funds, again, for mental health services and bonuses to medical practitioners. So we have 15 primary community mental health agencies here in our state, and each received a proportionate amount of these dollars to use to further support additional sign-on or retention bonuses for full-time or part-time licensed staff, as defined by our TCA 631201. You can see the positions there that this pot of funding was relevant to. The providers also had the ability to go above and beyond to use these funds to plug in gaps in other mental health services. And again, as you can see here, these services have been unique to each provider and also have been used to build out infrastructure. So thinking more about how do we expand access to care? Several of the providers have used their share of these funds to expand office space, treatment space, all of which we know is important as the need continues to grow for mental health services. You can see since the program inception, 829 individuals have received a bonus under this fund or under this pot of funding. Most of these dollars have really gone towards services. Next slide. This is what I believe the commissioner was referencing earlier on. One of the other strategies identified by our work group is how do we get more people into the field who are not here already? And that's where we came up with the Tennessee Behavioral Health Pathways Scholarship. We can go back to that. There we go. And if I'm running short on time, Alicia, Debbie, let me know. I'll speed through the rest of these. But you can see we received also $3 million in new state funding from our special session to create the scholarship program. The great thing about this is we are investing in people on the front end, people who are looking to get a graduate degree, a master's degree in social work, in psychology, in marriage and family therapy. We are paying up to $15,000 per academic year, up to 2 years on the front end. So individuals are not having to take out student loans, or not having to come out of pocket for them to obtain an advanced degree in a behavioral health related field. The key here is that they have to commit to working for a equivalent amount of time to an agency that we contract with after they graduate. As Commissioner Williams referenced, there's been over 800 applications submitted for this scholarship, and that was just over the course of a 2-month application period. As of December of this past year, 194 students have received the scholarship. Actually, in the governor's budget for FY26, there's an additional $4.4 million for us to expand this scholarship program even further, hopefully getting to the remainder of these applicants. We recognize there's probably even more pent-up demand, but this is another example of the workforce work group's impact on helping us address the workforce shortages in our state by investing in people on the front end. Next slide. Another thing that we've done, again, this was something identified by the work group, is going beyond just people in college-age Tennesseans. How do we better connect with high school students, people who are at the formative years in their lives trying to figure out what they want to do when they become an adult? So we partnered with the University of Tennessee in Knoxville and the University of Memphis, and they've been doing outreach to local high schools, both in urban and rural areas, talking about career fields within behavioral health here in Tennessee. This is just, I think, another example of where we're thinking as far upstream as we can possibly get in getting more people into the field, helping people understand that you can have a great career in the public behavioral health system. And again, we're doing it at an earlier age, providing that education to high school students. You can see here on the slide, we've also, in partnership with the University of Tennessee and University of Memphis, created a podcast that we promote. You can find more information about all of this work on the link here on the slide. Next slide. I talked earlier about TennCare shared savings, and for the sake of time, I won't get into all of that. But some of the funds that our Medicaid system is saving is being reinvested in the behavioral health system. This is one example of that, the licensure supervision support program for community mental health centers. So this current fiscal year, our department received $1 million from TennCare to basically offset cost that we know community mental health agencies incur to provide clinical supervision to people pursuing a clinical license. If you've ever pursued clinical license, whether it be as an LCSW, a marriage and family therapist, you know it's expensive. If you've ever provided supervision, you know there's a cost that is born out of that. These are funds that go to help offset those costs. And as you can see, just since we started about 8 months ago, close to 400 people have benefited from this clinical supervision fund that we have in our state. Next slide. And I think that's it. So hopefully we wrapped up in time. Debbie, Alicia, if there's any questions, happy to address them.
Thank you so much, Deputy Commissioner. And thank you, Commissioner Williams. We're very honored to have you here with us today. And we hope that what you've done in Tennessee will give inspiration to other states. And as a fellow social worker, both Alicia and I thank you both for your dedication and your care for getting more people in the workforce in Tennessee. So we truly appreciate it. So thank you so much for joining us today. We're going to talk some more about Medicaid, as the commissioner and deputy commissioner talked about, and how that's a very important part of the program to the states. In fact, Medicaid, as you'll hear from our next speaker, Allie Gardner, is the primary payer for mental health in a large part of the country. And I don't mean just hunks of the country, I mean in large. So we're going to hear a lot about that. We know there's a lot going on. We are very, very happy to have Allie with us today. And she is a research fellow at the Georgetown University School of Policy, the Georgetown University McCourt School of Public Policy and the Center for Children and Families. She focuses on Medicaid and CHIP, and she's really a tremendous expert. And she's going to tell us about what could be in store for 2025. Allie, let me turn things over to you, please.
Thanks so much, Debbie, and thank you everybody for joining today. I'm trying, oh, there we go. Back slides, there we go. So I'm just gonna hit the ground running. I know we don't have a ton of time today, and there is a lot in store potentially for 2025. Starting with what is currently happening in Congress, which is last week, the House passed a budget resolution out of committee that sets up a number of cuts across committees, but specifically for the purposes of this conversation, sets up a potential sets a floor of an $880 billion in cuts for the Energy and Commerce Committee, which covers Medicaid. The Trump administration has already said they're not planning on making any cuts to Medicare, and the other areas for which the committee has jurisdiction are not large enough for them to not go after Medicaid. So most of the cuts we're expecting to meet that $880 billion floor, and again, they can go above that in terms of the number of cuts they make, we're expecting to come from Medicaid. The actual budget resolution is very sparse on details of where these cuts could come from, but previous proposals from the House Budget Chair, Jody Arrington, as well as other GOP documents and presentations have included things like capping federal Medicaid funding, adding work requirements to some or all adults on the Medicaid program, ending the 90% match for the expansion population, and changing how states can use provider taxes to fund their share of Medicaid spending. And in addition to all of the debate going on in Congress, some states have decided not to wait to try and implement new barriers to coverage for folks on Medicaid and have begun the process of seeking something called a Section 1115 demonstration to implement work reporting requirements for adults enrolled in Medicaid. Sorry, I'm trying to change the slide. If somebody can change it, please. It's not letting me. Thank you. So work requirements were perhaps the hallmark Medicaid policy of the first Trump administration, with 21 states requesting to implement the policy on some portion of Medicaid enrollees, and 13 states ultimately receiving approval from the first Trump administration. Ultimately, though, only one state was implemented the policy, which was Arkansas, and 18,000 people were disenrolled in the first 3 months that that policy was implemented. Other states that had received approval were later had their approvals rescinded by the Biden administration, though Georgia currently has a work requirement, though they are not disenrolling anyone because their work requirement was reinstated by the courts. As I mentioned, some states are taking an early start to reattempting work requirements, with Arkansas, Ohio, and South Carolina planning or already starting the process of submitting a new Section 1115 demonstration to adopt the policy, and Georgia seeking to renew its authority for its requirements. However, with all of these proposals, it's worth noting that the requests that we're seeing are arguably a more watered down version of those we saw the last time around, and they no longer require monthly reporting of work, and they are not disenrolling individuals for not meeting work requirements until renewal, and they're trying to use data to automatically determine compliance. With that said, though, many individuals that have disabilities or that have certain chronic conditions or mental health conditions that would otherwise be exempt under previous proposals would not be exempt under these proposals as planned. Congress is also discussing adding a mandatory work requirement to Medicaid, which would make those 1115s unnecessary. And based on estimates from the Center on Budget and Policy Priorities, that would put approximately 36 million adults at risk of losing their Medicaid coverage. And as these discussions continue, it's very important to highlight that the people on Medicaid are already working. There's great data from the Kaiser Family Foundation on this. So work requirements are not actually about work. They're about adding bureaucratic red tape that keeps eligible people from receiving coverage. Also, as I mentioned, even if state proposals or federal requirements say that there are exemptions for individuals with certain health conditions, these exemptions are very difficult to document and prove in order for those folks to actually be exempt. Next slide, please. I'm not going to go through, you guys have probably heard these terms before, so I'm not going to read through the slide, but while Speaker Johnson and other House Republicans have said they are only looking at work requirements and proposals that target waste, fraud, and abuse, their estimates only show about $110 billion in savings from work requirements. So that means that they're potentially exploring other ways to cut Medicaid, which brings me to another key area that congressional Republicans have long targeted for Medicaid cuts, which is changing the current financing structure of Medicaid, which is currently an open-ended entitlement, to capping federal funding at a fixed amount, either as a lump sum block grant or a cap on per enrollee spending. Either type of cap would result in significant cuts over a 10-year period, as you can see demonstrated by the graph on the right, and would force states to make difficult decisions about who they cover, who is eligible for Medicaid, the benefits the state covers, as well as provider payment rates, as significant portions of Medicaid spending are shifted to states. Next slide, please. So while work requirements and capping Medicaid funding are currently being discussed the most, especially in the media and being highlighted, there are also other threats that have been discussed as possible targets, all of which would impact mental health access for not only adults, but other people on the program. If the 90% enhanced federal matching rate for the expansion population were lowered or eliminated, There are currently 9 states, which are listed on the slide, that have state laws which would trigger an automatic repeal of their state's expansion. And then there are another 3 states, New Mexico, Iowa, and Idaho, that have language that gives the state authority to drop expansion or requires reconsideration of covering the expansion population. It's really important to note that any cuts to expansion will not only affect the adults enrolled in the expansion population, but will affect the entire program as states grapple with how to adjust their Medicaid programs in response to increased costs, more uninsured individuals, and just overall kind of disruption to their healthcare systems. There are also a range of potential changes to the minimum federal matching rate, which would disproportionately harm blue states and the District of Columbia. For example, there's one proposal that would essentially eliminate any federal matching dollars for the Medicaid program for DC, which is currently 70% in terms of the federal to state cost split. And finally, as these giant cost shifts to states are being considered, there are also proposals that would limit states' ability to fund their potentially increasing portion of Medicaid spending. And this would currently is being discussed in the form of changing how the provider, how states can implement or impose provider taxes on providers. So next slide, please. So bottom line, that's a lot of scary, but it's really important to highlight because there's so many effects that this is going to have on a national basis, but especially as state by state. When we're talking about the impact of these policies, the magnitude of cuts on state budgets are greater than they may appear. And this is in part because of what we call the multiplier effect. So because of the federal matching rate, if a state ends up cutting $1 in state Medicaid funding, that is overwhelmingly a $1 loss in federal Medicaid matching funds. So using this as an example, if a state cut $1 in spending on the Medicaid expansion population, that means that they also lose $9 in federal funding, which equates to a total of $10 in cuts to of dollars coming into the state, which overall means a budget cut to Medicaid is much larger when the states are thinking about having to shrink their programs or things like that. Any of the cuts being considered would ultimately be a very large cost shifts to states, as I've said multiple times now. And this will force states to grapple with either raising taxes very substantially or severely cutting other parts of the Medicaid budget if they want to continue current Medicaid operations as they are. More likely is that states will end up having to make cuts to eligibility, benefits, or provider and plan payment rates to make up for the losses of federal funding, which will affect individuals' health insurance coverage, as well as what services are covered, and then obviously people's ability to access services as provider payment rates are adjusted. Next slide, please. So I promise there's going to be a positive piece of this. But as we kind of think about how to approach talking about these Medicaid cuts and who could be affected and really humanizing things in terms of what Medicaid means. I think for this group in particular, as we think about mental health and mental health care access, there's a number of populations that could have access affected or eliminated altogether that may be really helpful and important to highlight in discussions that you're having about the role Medicaid plays for mental health care. For example, 1 in 10 veterans who I'm sure many people know have high rates of PTSD and other mental health conditions related to time in service are covered by Medicaid, many of whom are eligible through Medicaid expansion. Perinatal mental health condition or healthcare, which has been a focus in both red and blue states, would also be at risk, which is many people don't think about immediately because we have the 12-month postpartum option. But that 12-month postpartum extension is optional. So if states are forced to make difficult cuts to eligibility or benefits, those postpartum expansions that almost every state has taken up could be on the chopping block, which could affect new moms' access to important important mental health care for postpartum depression and other perinatal mental health conditions. And as you're again thinking about these types of key populations that could be affected, that resonate with the public and congressional representatives, this is going to be very helpful in humanizing the impact of potential cuts and can help in building coalitions to work to protect Medicaid. And so then we think about the potential mental health services that could be in jeopardy, or things to consider and highlight in terms of why Medicaid is so important. Is, if states chose not to target cutting eligibility to try and to try and cut funding if Congress moves forward with these cuts, states could cut optional Medicaid services. And while there are a number of benefits on Medicaid that are mandatory for states to provide, there are also some really important benefits and services that states are not required to cover. And the best example of this across the board is prescription drugs. This is an optional benefit, which I don't think a lot of people realize. So I think in practicality, most states may not eliminate coverage of prescription drugs entirely, but they could severely restrict the types of drugs covered, limit access to specialty care drugs, choose not to cover new groundbreaking medications that are coming onto the market, all of which could affect access to care for folks. And as we kind of talk about, the theme of this is thinking about the Medicaid multiplier and how Medicaid reaches into so many different facets. And so one thing I've been emphasizing as people are talking about just things being cut for the expansion population is because of the number of people who would become uninsured if things were to happen negatively to the expansion population, if work requirements were implemented and a lot of people lost coverage. While kids aren't directly affected in those proposals, it could affect kids more broadly as it affects provider access, as providers are not able to take Medicaid anymore, or have to close because there's more uninsured people, especially as we think about rural areas, or where there aren't a huge number of providers. So just as you're thinking about the potential impacts, even if somebody says they're not going to target children, or children are not going to be affected, the ripple effects of all of these proposals could absolutely benefit kids, pregnant women, and the vulnerable populations that some folks are saying that the cuts are intended to protect. Next slide, please. So, like I said, it's not all doom and gloom because nothing's happened yet. So there is an incredible opportunity, especially over the next week, before Congress votes on a budget resolution, for you to work with coalitions to educate people about how these kind of cuts would, the potential harmful impacts these cuts would have on your patients, providers, state budgets, everything we just kind of talked about. And, I throw out as a reminder, during the 2017 repeal and replace battle, in many ways, Medicaid saved the ACA during this because of the large public outcry about cutting Medicaid and what that would mean for communities and healthcare providers and states in general. And I think we really saw this a few weeks ago with the pause on federal funding and the resulting issues with the Medicaid payment system, which sparked a huge public reaction and showed why outcry matters. And I think you're also seeing that in press coverage right now about Medicaid potentially being on the chopping block, because people realize what's at stake if Medicaid's cut, what that means for congressional districts, what that means for real people, for services folks care about. And so with all of this, I think it's really important. Again, we don't have details on what kind of specific cuts could be on the table, but I wouldn't wait until we see any kind of legislation to start doing education and outreach and trying to build coalitions. I think we're expecting the House to move quickly. And so going ahead and kind of doing some prep work now and getting out there with your voice to tell people why Medicaid matters to you and your communities. And most importantly, it's been a very, very difficult time. Take care of yourself. And I so respect all of the work that you guys do. Glad to have everyone here. And again, really appreciate the opportunity to highlight this.
Ally, thank you so much. And we agree with you that we have to take action now. You did put forth a lot of scary, and we have the power to stop some of that scary and hopefully make all of that scary, because we know how important Medicaid is to the people that we serve and the people that we care about. So I invite everyone, please, to take a minute and scan that QR code that you see right now on your screen and take our action alert, which will take you right to your congressional representatives, and you can tell them why it's important to you and speak about some of the things that Ally spoke about. So again, Ally, thank you so very, very much for joining us. Your expertise is so appreciated. When you have Medicaid is an important part, but there are other parts to getting people access to the coverage that they need. And parity has played the biggest part in that, and it has been tremendous over the last 12 years. And we are so privileged at Mental Health America to have Tim Clement, who is without a doubt one of the national experts when it comes to parity and coverage, and our own Barb Johnston. And Barb is one of our Regional Policy Council representatives, and she's from our MHA in New Jersey. And the two of them are going to talk about why parity is so important and what's happening and what you can do. So Barb, Tim, please take it away.
Great. Thanks, Debbie. Hi. We're happy to be here today. Tim and I are going to talk about parity. We're going to tell you a lot of details about what it means so it comes to light for you. Tim's going to talk about the laws that exist, the application of those laws, some of the compliance challenges that we have, and best practices in the states. And then I'm going to talk about some of the things that we've done and that we all can do around advocacy and opportunities for advocacy. So next slide. So parity means that insurance coverage for behavioral health, mental health, and substance use disorders should be no more restrictive than for physical health care. So for mental health and substance use restrictions, they cannot be more excessive than those that exist for physical health care conditions. So next slide. Tim?
Yeah, thanks, Barb. So that's a very simple concept we have parity. It's just it can't be more restrictive. So it doesn't mean things have to be exactly the same. Just your mental health and substance use can't be more restrictive. There's no reason why you can't have more generous mental health and substance use disorder coverage. Just can't be more restrictive. So the concept by itself is very, very simple. And the federal law, there's many state laws in place, but the federal law that sets the baseline for the concept of parity is the Mental Health Parity and Addiction Equity Act of 2008, or the federal parity law, that was signed into law by President George W. Bush on October 3rd, 2008. So it's been over 16 years. And it was last amended back in 2020. President Trump signed a significant amendment to the law. Now, we just said it's a very, very simple concept, and it is. However, the law itself and its implementing regulations are incredibly complex. So sometimes people ask me, why are we still talking about this all these years later? In the fact that, this law has been in effect, how come, there's still questions? Are people actually following the law? Well, it's really, really, really complicated, the law itself. And so that's part of the challenge that we've had over the years. And also one thing to understand about the parity law, it's a foundational anti-discrimination law. I mean, that's at its heart, that's what the parity law says. You cannot discriminate against people with mental health conditions and substance use disorders and in your insurance coverage. And the reason we needed a law like that is because there was rampant discrimination in insurance coverage before the law took effect. And now there were new implementing regulations that were filed, that were finalized at the end in September of last year. They'd initially been proposed in the summer of 2023. We won't get into the weeds about what those do. They add a little more certainty and clarity, some clearer benchmarks about what is and what is not a violation of the law if those rules do in fact take effect. However, there was a court challenge filed by the ERISA Industry Committee. That's a group that represents mega employers like Comcast and Pepsi, so forth. They've filed a challenge to the rules. And so we'll see how that plays out. Of course, that will take quite some time to take effect. So we'll see how that affects the rules themselves. But even if those rules are not to stand, most of the law itself is not under threat. So and a lot of that has to do with the amendment that President Trump signed in 2020 that establishes some clear guardrails. And so the court challenge is concerning, but even if that were to go against us, it wouldn't be the end of the world. Okay, next slide, please. Okay, so there's some complexity to this, as we've already mentioned, but the parity law applies to pretty much all insurance types except for Medicare. So nothing under Medicare is covered under the parity law. So for most other insurance, you have private insurance, whether it's individual market, whether you get it for a small group market, whether it's a large employer sponsored plan, pretty much all private insurance. And for the most part, anyone that's on Medicaid is subject to the protections of the federal parity law. There are some very narrow exceptions for both private insurance and Medicaid, but very, very tiny, very small. So for the most part, unless you're on Medicare, you're probably covered by the protections of the federal parity law.
And just to jump in here for a sec, Tim, one of the things that we get questions about a lot is how about the Medicare Advantage programs? And they are also exempt from parity. So if there are violations that occur within those programs, they are not covered under the parity laws.
That's right. And you see that sometimes in Medicare Advantage. You'll notice that cost sharing for mental health and substance use services is significantly higher than it is for medical care, which that would generally be illegal under the parity law. But as Barb just said, and as we've noted, it does not apply to any forms of Medicare, including Medicare Advantage and including to Part D as well, prescription drug. And now we just talked a little bit, okay, why are we still talking about this? Well, there is significant non-compliance with the more really complicated parts of the law, the insurer's managed care practices. So what do we mean by that? Prior authorization, step therapy, how insurers design their provider networks, network adequacy, can people get access to care, reimbursement rate setting, and a lot more. There's tons of stuff that fall under this umbrella, but this is where we see lots of sort of issues when it comes to non-compliance. A lot of state regulators have found direct violations, and we'll talk about that in a minute, in this realm. And in fact, the law was amended a few years ago to cover some of this. But that's really where we see a lot of the problems. So when it comes to all those things as it relates to can people actually get access to care, that's where we're still seeing some of the issues. And so because of that, starting about 2017, 2018, a lot of state insurance departments started looking into compliance with the law, especially those managed care practices. And every time they looked, they were finding problems. So what that led to was a push for increased transparency. If keep in mind, it's a comparative law. You have to compare whether your mental health and substance use benefits are comparable to what is going on for medical care. How else could you know that you're meeting those requirements unless you've done some sort of analysis? So that form of reasoning was very persuasive. And so what happened is the amendment that President Trump signed in 2020 now creates a built-in transparency function. So essentially, all insurers and health plans throughout the country now have to prove that they're following the law as it relates to those managed care practices, and they have to submit that proof, those analyses, to the federal agencies and also state insurance departments as well upon request. So that's now we live in an era where there's enhanced transparency and also sort of perpetual or enhanced oversight as well. Next slide, please. Back one slide. Thank you. Okay, so starting in 2018, so we'll go through some of the best practices of states. So in the state legislative realm, we just mentioned how the federal law itself was amended to have that built-in transparency. Well, states actually beat Congress to the punch. In fact, states are what started the push for that enhanced transparency. And in fact, Illinois, as we heard earlier, Illinois has long been one of the leading general assemblies in passing proactive, strong behavioral health legislation. They were one of the first states to pass parity transparency legislation. So over 20 states now have laws on the books that require insurers and in many cases Medicaid managed care organizations to submit those analyses I was just talking about to the state regulators every year for the rest of time, proving that they're following the law. So that was actually what convinced Congress to take action, because the argument in Congress was, well, states are passing these laws, but there's a lot of health plans that states can't regulate. So you need to do something, Congress, and make a level playing field for everyone. And that's what they did. And that was the amendment that President Trump signed into law in 2020. So that was a big push that happened over the last 6 or 7 years. There's not as much activity on that front anymore, because now that the federal law has that built-in transparency, states they can rely on that federal authority to force the transparency from the insurers that they regulate. Several other states have passed laws requiring insurers to follow what are known as generally accepted standards of care when making coverage decisions. So in other words, using standards like the American Society of Addiction Medicine for making substance use disorders and any kind of and the kind of tools developed by nonprofit specialty societies instead of those profit-driven criteria. And what this came out of, there was a court case 5-6 years ago called Witt v. United Behavioral Health, and the court ruled that United, they were not using the criteria that was sort of the generally accepted standards of care. They were using criteria that was actually basically created by their finance department to help save the money. And so the court ruled against United. And after that, in the wake of that, a number of states, including California, Illinois again, Oregon, and Georgia has a sort of scaled down version, and also New Mexico have passed legislation basically requiring insurers, when they make their decisions about what's going to be covered and what's not and what level of care you get, they got to use those generally accepted standards of care. And of course, Illinois, I won't go into Illinois. I think Mark very comprehensively covered what the most recent legislation that that Governor Pritzker led and signed into law, while Governor Pritzker was getting an award today. But that was another piece of great legislation for the state of Illinois. They've been doing that on behavioral health all the way back since 2011. They passed some first in the nation legislation. I won't go through all the things, but again, that's Illinois has definitely been at the forefront of leading the edge in state legislative activity around behavioral health. Next slide, please. Okay. All right, so I got at this a little bit earlier, but one thing that's been happening a lot, so before the law was enacted in 2008, but there hadn't been a whole lot of enforcement really by state or federal authorities until 2017, 2018. A lot of it had to do with the fact with just after the parity law was enacted, the Affordable Care Act was also signed into law, and that took up a lot of the oxygen for state insurance regulators and federal agencies. But starting in 2017-18, states started again looking into the behavior of insurers, and they found problems everywhere they looked. I remember I meet frequently with state regulators, and the saying is, if you look, you will find problems. So that was pretty much the case. So too many states to name. Lots of states have issued findings of noncompliance for violating the federal parity law over the last 6, 7, 8 years. But recently, 2 states, very conservative state North Dakota, not as conservative state Virginia, issued very aggressive findings of noncompliance. Basically, what these 2 states found was, so we just talked about how there's those transparency requirements. Insurers basically have to prove that they're following law to follow the law. So you have to prove you're following the complicated parts of the law to follow the law overall. These insurance departments found that the insurers were not doing that. Their analyses were terrible, they weren't good enough, and therefore they were going to be found out of compliance with the law, and that's what they did. So that's something that's also the federal one of the federal agencies did that as well in their recent report to Congress. So we're seeing regulators now move into a posture where they're saying, if you're not going to prove that you're following the law, we're going to find you out of compliance with the law because we have that authority now. So it's a sort of a new era now of enforcement. Okay, next slide.
Yeah, so what do we do with all of this? Well, it's really critical, as Tim said, to know where your own state stands in terms of parity. Obviously, we have the federal legislation, but for example, New Jersey had 2 prior laws on coverage for opioid addiction and for individuals on the autism spectrum. And so coverage was enhanced and they were considered parity laws. And then, of course, we were one of those states in 2019 that implemented parity legislation. So know what your state stands, where they stand in terms of implementing those laws. Next slide. And then know and understand who's accountable to implement the laws. So it will either be your state Department of Insurance for the small employers, small employers, medium-sized employers, the individual plans. For Medicaid, it is your state Medicaid department. And for those large self-insured plans that Tim referred to as the ERISA plans, they are under the accountability of the Department of Labor. All of those areas are interested in assuring accountability to varying degrees. So these are who we appeal to. So for example, in New Jersey, we are actively working with our State Department of Insurance around the implementation of our most recent transparency legislation, and they are in the process of implementing it. It's not fully implemented yet, but we're working on it. So next slide. So you want to know who your payers are in your state and who covers what. So for private insurance, you'll often see Blue Cross, United, Cigna. For Medicaid, you're going to have specific plans that are your Medicaid providers, and Medicaid is administered under those plans if they're carved in. And then, of course, your large employer-funded plans, and they hire some of these same plans to administer the actual parity implementation of utilization benefits. So you have to really have a basic understanding of who exists in your state in order to do advocacy with all of those groups. Next slide. So very critically important are the people who use behavioral health services. And it's very important to have a good avenue of receiving complaints about access to care, about where people have examples of where parity may not be equitable. One example that came to me recently was just taking a look at some of the inpatient settings where very often a prior authorization is required before hospitalization. But in some of the inpatient settings, some of the plans are requiring what they call a concurrent review every single day, which is administratively intense. Does that same review exist in other equitable physical healthcare settings? So that's the kind of thing that it's really important to keep an ear to the ground and know what's happening in your state in terms of those kinds of restrictions and taking a look. And you want to make sure that you document them carefully, date, time, place. And if people are not willing to come forward, as we know, there's so much stigma involved with mental health and substance use conditions, please take the complaints and work with the people. And you can do that anonymously very often, as long as you have date, time, place, and a lot of the other information. So stories matter. We know that legislators must hear the humanizing impact of what these violations mean to people, how they affect their lives, just like we're doing today for Medicaid, to make sure that legislators understand why these cuts and why these violations matter so much to the people in our lives. Next slide. And lastly, for advocacy, keep educating everyone. One shot doesn't do it. Information, newsletters, webinars, just, be available to hear people's stories and make sure that you continue regular communication with all of your constituents. Next slide. So Tim and I are available for follow-up questions. I think we don't have time for Q&A, right, Deb? But here's our emails, and we're happy to respond to any questions that you all may have.
Thank you, Barb. Thank you, Tim. That was wonderful. Feel free to put your emails in the chat and then folks can get to you. They'll also be getting the slides. We are so lucky to have such expertise. And if you all are picking up a theme here about speaking out, you're noticing it, and we're going to hear about speaking out some more. So we know that Medicaid is the biggest payer in the country. We know that private insurance matters. We know parity matters in private insurance and in public insurance. And what if you've done all the things that you can do and you're still being turned down? Well, we're going to hear from Joe Feldman of Cover My Mental Health. And Joe's going to tell us about some of the things that people, individuals, families can take on their own behalf and on behalf of their loved ones if they're still not getting what they need. So Joe, we're so glad you're here with us, and thank you. I'm going to turn things over to you.
Great, Debbie, thanks for your kind introduction, and it's a pleasure to be here today. You know, the one thing I think the parity law does do and has done right from the beginning is set the right expectation, which is to say the right expectation is that mental health is health. And that's, I think, what this organization, Mental Health America, at a national level and across all affiliates believes. Cover My Mental Health was started a year ago. Our website's been up for about 9 months. So we're a relatively new resource, and our objective is to support patients and families and clinicians with two things. First, we want to provide encouragement that you don't have to take no for an answer, that your reasonable expectations about how health insurance should work are in fact reasonable. And then we provide resources that you can use today to push back on insurance company obstacles. So in my remarks, I'll provide a flyover of the kind of resources that we provide. And at the end, I'll describe some ways that we are already collaborating with some MHA affiliates and others, and we'll leave the door wide open for more. Next slide, please. So if we pause to think at all about health insurance when we first got coverage, which I would say most of us don't, but if we did, we would think about it, I think, in the way described on this chart. We would expect that the insurance company is going to help us get access to the right clinician, that the insurance coverage is going to be clear, which is to say, if the clinician tells us we need therapy, we need a certain medication, we need a higher level of care, whatever it might be, that's what's going to be covered. And as the treatment progresses and we're working with the same clinician or maybe another clinician, that progression of treatment is going to continue to be covered based on the expertise of the person who has the most knowledge of what we need, which is to say the clinician who's taking care of us. And finally, we expect that claims are going to be paid. So there'll be deductibles and co-pays. And there might be limitations for in-network versus out-of-network. But the expectation is that claims are going to be paid. And the expectation is also, if there's a dispute along the way, that it'll be resolved. It might be an administrative glitch. It could be some other concern. But the idea is that we would expect it's going to be resolved, certainly in the interest of the patient. Next slide, please. So we wouldn't be here today if it all went according to expectations. So what we know from, in many cases, our own personal experience and from the people that we work with and get to collaborate with is that it's just not that simple. And when people say, well, at least I have health insurance, that it might not flow through to the level of coverage and support that we would expect. So our resources on Cover My Mental Health address some of the most common obstacles that stand in the way of people accessing healthcare. And we describe the specific steps that are available that you can take today before the dispute resolution path that insurance companies tell you is available, which is a formal appeal. It turns out there are many steps that you can take ahead of time that might be successful in overcoming the obstacle. And even if you need ultimately to pursue an appeal, having taken these earlier steps might make it that much more effective for you. Next slide, please. So the first expectation that I identified is that your health insurance company is going to give you access to an appropriate clinician. And I think appropriate falls or is categorized in maybe three ways. First, it's a clinician that has the right expertise for the particular concern that you have, or is in a position to direct you to the right clinician. And the other two characteristics that are important is that the clinician is close to you and that you can get an appointment soon. It's up to the insurance company to provide you with a directory that gives you the ability to do your homework, to find a clinician with the right expertise who's close to you and for whom you can get an appointment sometime soon. So one of the resources that we have available on the website is a worksheet that makes it easy to show your homework, to show that you used the directory and you reached out to, say, a handful of clinicians or maybe more, and you've tried to get an appointment nearby, soon, and it hasn't worked. And so the worksheet gives you room to put check marks in. For example, the clinician is no longer in the network, or is not taking new patients, or offered an appointment in April of 2027, or it turns out they never were in the network and they really don't know why they were even in the directory. The whole idea is to deal with the obstacle of a network that really isn't there. Sometimes you hear the expression a ghost network, and to be able to go back to the insurance company and say, I've done my homework, now it's up to you to do yours and help me to get an appointment with someone in network or to cover my care with someone who is not in the network. Next slide, please. So when it comes time to think about expectations for your insurance coverage, the expectation is really simple. I don't want to be surprised. If my clinician tells me that this is the care I need or the medication I need, it seems like that's pretty obviously what the insurance company ought to be covering. And as that treatment progresses, the coverage will be in place. So why does it not work this way? So I think it might be clearest if I tell a very brief story of that a psychiatrist friend of mine told me. And it goes like this. Every health insurance policy, at least every one that I've ever seen, has a provision that says that they'll cover medically necessary care. That's the key phrase, medically necessary. And this friend of mine who's a psychiatrist said, we don't learn about medical necessity in our clinical training. What we learn about is do no harm, so the Hippocratic Oath. We learn to use safe and effective care. And then finally, we apply generally accepted standards, and that's really the key. And so when generally accepted standards, which by the way were mentioned earlier today, when generally accepted standards are not synonymous with medical necessity, that's where you have room for an insurance company saying, we don't think the care is medically necessary, and the clinician says, well, it absolutely fits in with the generally accepted standards. So while it's helpful that some states, Illinois being one, have said that medical necessity has to be based on generally accepted standards, that doesn't necessarily mean that they're going to be interpreted the same way. And so you've got this potential for a gap between those two standards of evaluating what does the patient actually need. So what do we do to close that gap? Next slide, please. So I refer to a medical necessity letter as someone's not so secret weapon in closing the gap between an insurance company saying not medically necessary and a clinician saying it absolutely is appropriate care based on generally accepted standards. And our website has a wide range of downloadable resources in Word typically so that they can be modified for use. And one of the ones that I think most proud of, because I think it has the most potential impact, is this template medical necessity letter. It was developed with input from a very wide range of experts, litigators, appeals experts, former insurance company executives, clinicians, and state and federal regulators too. And the contents of the medical necessity letter are, in a way, what you would expect in a conversation between a clinician and an insurance company. And it's summarized on the slide as follows. The clinician is saying, here's my training. I was trained at such and such a medical school or such and such a psychotherapy program, and I practice in this area, and I've been working with this patient for some period of time. And here's my relationship with the patient and my clinical assessment. And I'm applying generally accepted standards, and those standards are specified. And then, most importantly, the clinician signs the letter that says that the following XYZ is their determination of the care that is medically necessary. So this is a document that can be provided, that should be provided to the insurance company to establish the primacy, the authority of the clinician to make a decision about what care is medically necessary according to generally accepted standards. Next slide, please. So when I discuss the use of a medical necessity letter with clinicians, and I've had a chance to do that with literally hundreds of clinicians just over the last six weeks, the question they always ask me is, so when are we supposed to do that? And the general answer that I give is, it's at a time when you know, because you've received a denial, that there's a difference between the insurance company's view of medical necessity and the clinician's view of how generally accepted standards are being applied. They can also be used on a proactive basis based on the clinician's experience, knowing when an insurance company's application of medical necessity standards is very likely to pop up later and be a surprise. So I just want to mention a few examples here of when a medical necessity letter can make a really big difference. And I say that with the experience of having done so successfully for both of our kids when they've needed care that was medically necessary and the insurance company got it wrong, and having a medical necessity letter on file made all the difference in the world in having those denials overturned. So the first occasion that I want to highlight is when there's a change in level of care. So for example, when you're moving from outpatient care to really any higher level of care, intensive outpatient, partial hospitalization, and in significant cases, residential or inpatient care. It could also be based on medication, where earlier in the remarks about parity, there was a discussion about step therapy, which sometimes is referred to as fail first. The idea of the clinician says, this patient is presenting with bipolar. This is an actual story that I heard from a psychiatrist in the upper Midwest. And the absolutely clear medication decision was a long-acting injectable. And the insurance company said, nah, that's not really necessary. So this is an opportunity for a medical necessity letter to document the clinician's experience, training, and the appropriateness of the medication. Now, I have to acknowledge that these letters don't cause insurance companies to cave immediately. They don't say, oh my gosh, we totally missed it. Thanks for the clarification. I wish I could say that it does that each and every time and quickly. I can't say that it does that. What I can say is that it levels the playing field and changes the conversation and the obligation for an insurance company to receive the information from the clinician, which they are obliged to do, to consume it. So they need to acknowledge what the clinician is saying. And then if they still are going to deny, they are obliged to explain why they don't agree. So it's not 100% sure thing and quickly. It does, I think, level the playing field. The last example that I want to give is around prior authorization. So last year, at the very end of the year, the Department of Labor hosted a presentation by an expert panel of litigators and advocates to talk about what they could do at the federal level to improve their regulation of health insurance plans. And the last of the 12 recommendations was prior authorizations should be actual authorizations and they shouldn't be reversed. And I've had this experience in our own family where I got a prior authorization and then the explanation of benefits basically said, just kidding, we're not going to cover it. So having a medical necessity letter on file, even with a received prior authorization, could be quite helpful. Next slide, please. So if at first you don't succeed, then what? So there are a number of follow-on steps that are described on our website, and I'd encourage you to visit the site at covermymentalhealth.org, and you can take a look. I want to talk a little bit about formal insurance complaint, and I'll do that on the next slide. But I want to mention just two others that may not occur to you right away that I think are really important. The second bullet there, requesting a complete claim file, is something that is your right, a patient's right, under HIPAA. So we think of HIPAA as being a law that says don't disclose personal health information. It also turns out to include language that says you can ask your insurance company to provide you a copy of the complete file. And I've done this myself, and it's very helpful. You'll get a lot of information that you already have, and then you'll also potentially get information about their internal decision-making that's been documented around medical necessity, and that can be quite useful. The other is calling constituent services, so reaching out to your elected officials, either at a state or federal level, and asking them for their help. That actually works, and you can find on our website a video of a woman who works in the Texas legislature who stood up and sort of waved her hands when I was giving a presentation a few months ago. And she said, "This is exactly right. It's my job, and I love to help people with that." Next slide, please. So I think one of the most interesting potential steps that can be taken is this one, a formal insurer complaint. I learned about this from a close collaborator of mine who has worked for 3 different insurance companies running behavioral health units, and he now works for a nonprofit that serves uninsured and underinsured individuals in Chicago. And he told me about this, and I was fascinated, and I was also really shocked that I had never heard about it. So let me tell you first what it's not. It's not a state insurance or a federal or a regulator or a federal regulator complaint. Those are different. It's also not an appeal. It's an administrative insurer complaint. And our website shows the script, the very simple script that's shown here, that you would say to a customer service rep, for example, when you've provided a medical necessity letter and it's still not getting the job done, to say to the customer service rep, I want to file a formal complaint. It's for a quality of care failure. And the quality of care failure specifically is, I've got a medical necessity letter here from my clinician, and the claim is still being denied. So what's important about this is insurers are obliged to report on the complaints received and the disposition of those complaints. And even though the reporting mechanisms for those to their regulatory authorities and to their accreditation bodies are likely not until the end of the year, they must immediately log and track the complaint. And so this triggers a different work stream within the insurance company that could put more attention on your dispute and your assertion that the insurance company got it wrong. We also have on the website a downloadable a document that you can use to get started summarizing and writing the formal complaint that you filed. Next slide. So we at Cover My Mental Health are, I would say, in full alignment with Mental Health America about encouraging and empowering individuals to get the health care they're entitled to. And we welcome your reaching out to us to set up workshops or otherwise collaborate with us. And I'll end there, and thank you very much for this opportunity to be part of this presentation and celebration today.
Thank you, Joe. I think we have one more slide that has a QR code, in fact. So if folks would like to reach out or reach to your website or answer a survey about what they've learned today, and I know I've learned a lot, and I really appreciate it. Let me tell you, I've been around the block a few times. So thank you for all that tremendous information. Feel free to scan the QR code, and please do reach out to Joe. We'll also put his email in the chat so you can reach out directly to him. And thank you again. We truly appreciate it. And we know that sometimes things still don't go exactly where you want them to go, and folks end up in crisis. And now we're going to hear from Shelley Polanco. And Shelley, again, is one of our wonderful Regional Policy Council representatives, and she's also the Director of State Policy at our affiliate, our MHA affiliate, Vibrant Emotional Health, where 988 is based. Shelley, I'm going to ask you to not go into too much detail about the history, because our folks are really big on, they know it, and tell us what we can see that's going on right now and what we can do. So Shelley, please go ahead.
Of course. Thank you, Deb. Like Deb mentioned, my name is Shelley Polanco. I am the Director of State Policy for our Public Policy and Government Affairs team here at Vibrant. And we are the administrators of the 988 Lifeline. So I'll go to the next slide. And this is just a disclaimer. So the views and the opinions and the content expressed in this presentation do not necessarily reflect the views, opinions, and policies of the mental health services and substance abuse and SAMHSA or the Department of Health and Human Services. So just a flag there. Next slide. So like Deb mentioned, I just kind of wanted to quickly show an overview of just like the timeline, just to kind of really frame how much work has been done in just the last like 22 years, right? SAMHSA's beginning the work of the National Suicide Hotline in 2001, and then seeing how even just 2023, we have already created a 3-digit number that launched, right? That we have the chat and text services. We've launched specialized services for LGBTQ, Spanish chat and text services, and even the video phone. And obviously, 22 years is a lot, right? But just kind of really showing that so much work has been done, and there's just so much more left for us to do. And I just really wanted to, with all the knowledge that we've learned today in this presentation with our amazing speaker, just kind of bring us back to what's happening and currently in just the crisis system, and not just 988, right? But how can we really build out that continuum and that crisis service work in our state? Next slide. So I really wanted to kind of focus on here with the National Suicide Hotline Designation Act of 2020. This was the really rulemaking of the FCC that kind of gave that provided the mechanism and established 988, right? And then provided the mechanism for funding and gave the responsibility and implementation that, the system that design and long-term sustainable, and gave it to the states, right? And I think this is really important. I really wanted to highlight this because especially now, as we're seeing the current state, right? Just the country, how much things have changed and how the federal government has been just kind of doing some cuts here and there. And it's just not very sustainable or feasible, right? For the long term, as we are building out a system, we want to make sure that, the states really kind of get that support, right? To kind of create the crisis infrastructure that really applies and really, it is designed by the people in their state. And that way, how can we create that funding and that system that really reflects our residents and because every state is different, right? We don't want to kind of have a federal ruling and then think that it's going to apply to everyone. How can we really design a system that reflects us, right? That people see themselves in that system and in that framework and actually use these crisis services. And it's not something that someone else designed for us and it doesn't fit what we need, right? So next slide, please. So here's just some of the goals and just kind of the key objectives that we think we can be of support of building an integrated crisis system. So to build that system, it has to have an established comprehensive network of crisis care services that are effective, accessible, right, and even equitable and sustainable. I think those are going to be the 4 key aspects of building out a crisis system in a state. This system will ensure that every individual that needs can access a timely support through 988, through mobile crisis teams and other services, right? So how can we enhance local response systems? Not just 988, right? But how can we build out that system? How can we use 988 as a front door access, right? So for that immediate need at that moment, but how can we have those local resources so that people can actually go to a place to go, right? Or someone to come to rescue, right? To kind of give them that support, right? How can we ensure mental health parity? We heard about parity earlier in the presentation, but how can we really ensure that that is built into our system? Also, how can we support mental health awareness and service programs, right? There was a poll that NAMI did a couple months ago, and just kind of polling how many people are aware of 988, right? How many people are aware of this service? I've had several years working in crisis work, and it's surprising to me that how many people, until they're in crisis, they don't know the support that is out there. They don't know what service programs are there for assistance before they get to that crisis, before they get to that breaking point, right? So how can we build awareness of these programs locally, right? So that we are not getting people to crisis to be able to get them the service. Also strengthening mental health workforce. And we heard about workforce earlier from Tennessee, but how can we really strengthen our workforce in our state so that when people are in crisis, there's not a huge wait time for them to see a provider, right? That there's not a huge wait time for them to get to someone on the phone. That there are support systems there, and that we're not having people fall through the gaps of just kind of not, kind of getting fed up of waiting and not wanting to go through that process. And then increase in sustainable crisis systems capacity through dedicated funding, right? So funding is going to be important to support all these other 4 steps. So how can we really build an integrated system without money? Right? We need those dollars, we need that funding. And a lot of the work that my team does is kind of tracking how are states really going to fund and support these systems? How are states really looking for those dollars in their budget, in just creating in different bills, different legislation, right? So that can really support this system, and not just for right now because it's a hot topic, right? But for the long run. Next slide, please. So here are some of the building blocks for 988, right? And again, when I'm speaking about 988, I want you to kind of also see it as just the building blocks for not just for the whole system, for the whole crisis service. And we're looking at basically 3 pillars here. So creating that monthly 988 telecom fee, right? To sustainably fund 988 and the Lifeline crisis centers and systems that operate the same way as 911 and others, right? We have here in the state of Florida, we have 211, and other states also have other kind of 3-digit numbers that kind of connects them to some sort of services, right? So we've seen some states not only just support 988, but also kind of adding some support for their other lines as well. For number 2, establishing a dedicated 988 trust fund account. So this is going to be a way to store that funding. Sometimes some states have done kind of a trust fund without having a telecom fee, but this is just kind of to that funding source, right? So that kind of a bucket of funding for some services. So some states have done just for 988, some states have done 988 and other supportive services. So this is just kind of a place for that money to go to. And this is allocated to states 988 Lifeline centers, separate from the state's general fund. And number 3, forming a steering committee or advisory committee, right? So these would be various stakeholders from the state. So they'll kind of create a system. I know here in the state of Florida, we kind of have a committee here. And basically it's just people from different areas, whether that is a chief, from like a police services, mental health organizations, different things that coming together to really study our system, right? And how does that look like? How does 988 work with our crisis services? How are mobile crisis teams, varying in different counties and different, cities, right? Because not just because it's a state, every city and county is going to need different services and different resources. So these are just kind of 3 ways that we've seen states really start building those blocks for supportive mental health services, not only just through 988, but also just examining the whole system. Next slide. So here, as all of you know, there are 10 states that have enacted a 988 comprehensive like fee, basically. And here I just really wanted to quickly highlight just first of all, giving a shout out to all the work that our advocates have done in these states. You know, our legislators that have kind of, you know, worked to kind of provide this service and to really get this opportunity out there. You know, many of the states are already collecting the fee. I know that, and we'll get into it later, but I know some states are even revisiting their fees and how can they up the fee and even support more of their kind of the continuum and their 988 system. So just really wanted to showcase that even just a couple cents can really generate a lot of money for a state. And I just really wanted to kind of quickly just showcase some of the wording and the language that some states have done, that it's not just for 988, but also like their crisis response account, right? Like Nevada is doing, and other ways that they're kind of putting money into their mental health services. And this is going to be just generating money. It's going to be similar to the 911. So everyone has a 911 fee, and sometimes it varies by county. Like I know in New York City, they have a little bit of higher 911 fee than, let's say, someone up in, you know, Albany, right? Because they're going to have less of a need. So this is just kind of showcasing some of the kind of fee language that some of the states have been using to be able to successfully pass 988 fee. Next slide, please. So and then this is also public information. This is going to be from the FCC 988 report. So I just really wanted to highlight, like, let's look at Virginia, which was the first state to enact on 988 fee, how much money just 12 cents for their prepaid has generated, right? And in total, how much money that just 12 cents or 8 cents or 12 cents has been generating for the state. Now, all that money is going towards 988, their workforce, right? Their technology, their system, and how can that really be built into support, you know, just the crisis services in the long run for the state. So just really wanted to kind of showcase some of this. We don't have the 2024 one just yet, but once that comes out, again, it's public information, and folks can kind of take a look and just kind of, you know, see how these like couple cents have been very helpful for just the crisis system in these states. Next slide. Alrighty, so how can we really expand that 90-day system, right? How can we build more integrated and effective and useful 90-day services across the country? And these are some of the things that we have been seeing. Again, my team has been just tracking for the last 3 years, just kind of looking at what are states doing, right? How are the legislators or even bills really impacting the whole system in general? So for one of the things that we've seen, especially in the last year, just like the 988 student ID cards, again, this is creating awareness. And this is also kind of getting folks to really understand that there's a service out there. Again, that's one of the goals, right? To get people to use the service, especially as we're seeing more of our youth, really needing some support, right? So we've seen several states using this language and, you know, kind of providing K through 12 or post-secondary institutions with adding 988 in their student ID cards. We also seen language around if there's a student that students don't have IDs, or if the school doesn't issue IDs, that they have these resources posted around the school, or have counselors that are aware of the service so that they can see, they can share that information. We've also seen some training legislations as well around suicide and prevention, which is really great as well. Looking at liability protections for crisis centers, right? We talked about liability, we talked about parity. So how some of the legislations have come out that provided 988 crisis centers and their employees with protection for civil liability. So this is, you know, obviously when they were operating in good faith. And this is something that as a crisis counselor, right, we want to have as we're getting into this space and this work. And also one of the other ones was 988 and 911 collaboration. This has been something that since my time working within 988, we have had this conversation with several states, right? And some states have already a robust system, right, and have some collaboration. But we have seen some legislation that bolsters state and local efforts to increase collaboration and communication between 988 and 911 dispatchers. And this is just kind of I say it's always a good thing, right? Because that way we have a system that is talking to each other. We have a system that is working together. So instead of sending our law enforcement officer or an emergency response, right? How can we really communicate and work together to kind of, okay, this person does not need a law enforcement officer, they need a mobile crisis team, right? They need other services. So sometimes we've seen, them training together just so that they're also aware of each other's practices and different things that can be very helpful for that service. Also, the technology, right, is in centralized platforms, and I'm getting caught, my screen is a little cut off, so I can't see the last one there, but so technology and centralized platforms, right? We've seen some states have passed legislation to improve development and investment in their state centralized platforms. California did this a couple of years ago as well, creating a centralized platform to really have a unified system, right? So that the state is really working together with their 911, 988 offices, and how can they really build out a state crisis continuum of care. So they have a bill that kind of work around that, and they're still kind of building out that system. And then lastly, I can't really see it on the presentation, but the last one, I'm not sure if everyone else can see it. It's awareness campaigns, right? So legislation that increased investment in 988 marketing and awareness campaigns for the general public, and even targeted high-risk populations. I know Vibrant has done some targeted campaigns. SAMHSA has also done some targeting campaigns, but also how can states really support their crisis system and the populations? I know, and I'm just throwing some examples that are coming to my head now. I know that Georgia did a really great campaign regarding just restaurants workers, and they kind of did a really big campaign. I know Tennessee also kind of had like a student dedicated kind of sports campaign and things like that. So these are things that are like there's legislation to really increase 988 awareness in their state, right? So that people have access to this service. So these are just kind of great ways that we're just like expanding the system, and it's not really like funding related. These are just kind of integrated systems and underlining things that we're seeing states do. Next slide, please. So, okay, so I'm going to get really quickly into the current landscape. And this, again, these are things that some of the things that my team are tracking, the current bills that we are tracking and have been introduced. And again, these slides were submitted last week, so I know things are changing quickly, and some of these things might be moving and it's just not updated on the slide. So next slide, please. All right, so some fee bills that we are currently tracking. So New Hampshire currently has a bill that creates a trust fund with oversight provided by a newly established commission, and also establishes a fee, but it does not have a specific amount just yet listed on the fee on the bill. And then they also introduce a special 988 license plate. Some other states have done this as well, where you can kind of, when you go to get your license plate, you can pick the 988 plate, and when you pay for that funding that it generates, some of that is going to go towards 988 support, basically, and then just to kind of create some support as well and awareness for that. So we are tracking that one closely right now. Oklahoma as well. I'm sorry, I just got distracted from this lecture from the chat. So Oklahoma also has a bill that establishes a 988 crisis system, creates a trust fund. And again, they also have a fee amount, but it's not specified. They were supposed to have a hearing yesterday but that got moved due to the weather. So I know there has been some very inclement weather across the country. So we'll be tracking that as well as they reschedule that hearing. North Dakota established a 988 crisis stabilization fund. They did have a fee that was taken out earlier, I think this month. And now what they're doing is kind of putting some sort of appropriations to the human and the Health and Human Services department, and that's going to be implemented for 988 crisis hotline programs. Next slide, please. We are also looking, and then this is what I was alluding to earlier. Washington already has a fee and has established a fee for 988, but they have introduced a bill, and this one was from last week. There has been a new bill that was introduced by Senator Dringa. So it was from 40 cents. This bill was for 70. The new bill that was introduced earlier this week is to introduce it to 80 cents. So we're tracking that closely. So we want to make sure that we will see that and we'll share as that moves along. Texas as well has a 988 988 bill. It does not have a specific fee amount as well. And Debbie, I saw your message. I'm going to be wrapping up soon. So New York as well, they have this is the third year they have introduced this bill. We have been tracking this one and kind of connecting closely with our advocates there. And they are looking at a 35 cents telecom fee. That we are hearing that the governor is not in support of this bill just because of the high taxes in New York, and she has allocated some funding in the appropriations for 988. So next slide, please. And then this is just a couple student ID bills that we are tracking. Again, you'll get these slides, and if there's any questions about what can we do or how to get some of this information, more than happy to connect. But this is just a couple of the student ID bills that we are tracking as well, just to create awareness for our youth. Next slide. And this is another one. Next slide. And then this is just a couple other related 988 bills. Again, you'll get these slides if you guys have any other questions. This is just some 988 and 911 collaboration stuff that is happening in some other states. Next slide. And I just really wanted to highlight this one. And this is just some data that we have. I'm just highlighting how many people have reached out to 988 services. Our average wait times, our answer rates, just as a service, right? This is just very impactful that we are reaching 13 million calls, chats, and texts. So this is just from 20 for the last 2 years, right? How many people have been using this service. So it just kind of shows the impact and the need for the service and just crisis continuum in general for what's happening. And also 46 policy initiatives impacting crisis continuum were tracked. And this is not including what we're tracking this year. Next slide. Next slide. And these are just going to be some resources. These are the SAMHSA resources that were newly shared out. And these are just some links. Next slide. And then again, this is just the 988 Interactions NEMA report that was shared earlier this month as well. This is also new and has been in the works for a couple years. And then the Nashville model legislation, just kind of showcasing some of just helping out advocates as they're speaking to their legislators and need kind of a baseline of a bill, right? A skeleton of a 988 fee bill. Some states have used it and has been successful. So wanted to share that as well. Next slide.
Ellie, this is fabulous.
And that's it.
And folks are going to have so much information, and I know they're going to look forward to getting the slides and reading the reports. We truly appreciate having you as an RPC rep and all this good information. And folks, take state advocacy steps. Can we have the next slides, please? Thank you. I want to invite everybody to join MHA's virtual Hill Day for our affiliates. It will be on April the 30th. Please scan that QR code, and we welcome you to speak to your legislators, to take advocacy on all the things that you've learned about today. And other things that are happening. So we truly appreciate it. Next slide, please. I want to thank you all for attending. As we said, you'll get that email, you'll get a survey, you'll get the slides, you'll have a link in by email of the recording, and you'll have a survey. And we really appreciate if you take that survey and tell us how we're doing. Next slide, please. I again want to thank our industry partners that make our regional policy council meetings happen, and we truly appreciate you all joining us today. Thank you so very much. Good. Thank you, everybody. Thank you all. Thank you, Kat. Thank you, Alicia. Thank you, Jackie. Joe, glad you could join us, and great information. So thanks again. Okay, be in touch soon. Take care, everybody. Bye-bye.
Hey, you two were awesome. Thank you so much for being able to think on the fly and get this figured out.
Thanks, everyone.
Yeah, really appreciate you both.